Okay, we'll talk about now, we'll shift the gear into the most important topic that interests me, which is surgical management of atrial fibrillation. So atrial fibrillation is the most common arrhythmia affecting adults. It has 5-fold increase in risk of stroke and responsible for 30% of all strokes. Male patients with atrial fibrillation aged between 55 and 75 have a mortality rate of 61 compared to 30% in men with the same age group. According to this database, despite the fact that patients with atrial fibrillation have a survival worse than many malignancies, only 48.3% of patients with history of AFib undergo cardiac surgery have a concomitant surgical ablation. So as you can see here, this comes from the European Union. You see that atrial fibrillation is the most common cardiac arrhythmia causing fast and irregular heartbeat. Atrial fibrillation affected 33.5 million people worldwide and 8.8 million in the European Union. 1 in 4 persons over age of 55 years have atrial fibrillation. Its incidence increase with age, doubling each decade after 55, and the prevalence and number of individuals with atrial fibrillation will continue to grow in the coming years. What is the definition of atrial fibrillation? This is very important. This is taken from the Heart Rhythm Society published guideline 2007. Atrial fibrillation can be generally classified into four main types, which is paroxysmal atrial fibrillation. This is continuous, terminated in less than 7 days. Persistence, this is lasts more than 7 days and less than 1 year. Longest standing persistence, this is less, continuous for more than 1 year. And permanent atrial fibrillation, this is when the cardiologist and the patient come to the agreement that this is no further treatment will require. Medical management is composed of anticoagulation, as well as a rhythm for agent for rhythm and rate control. Failure rate of medical rhythm control medication is very high. Most of the medical management ultimately directed toward rate rather than rhythm control. History of development of atrial fibrillation surgery. In September 1987, Dr. James Cox performed his famous operation, which he called Cox Maze 1, by creating an atrial lesion set with cut and sew techniques, as well as ablation for the coronary sinus, mitral, and tricuspid annuli with cryothermia. Soon it evolves because of the risk of sinus node dysfunction and pacemaker. It evolved into Cox Maze 3, which produced an excellent result and rapid become the gold standard treatment, surgical treatment for atrial fibrillation. If you guys are interested, we can go over the operative technique of Cox Maze 3. I don't know if they're gonna ask you about it. I don't think they will ask you about it because this operation is almost nobody does it now because it's very complex and carries risk of bleeding, and because of development of the new technology that can be used to create a Cox Maze 3. So in Cox Maze 3, instead of doing the lesion set by energy source, you cut and you do all the lesions by cutting. So as you can see here, you cut to the left atrial appendage, you cut into the, like you make the straight line between the SVC and IVC, you cut into the right atrial body, then you brought your cryothermy, you cryo then you identify the coronary sinus, and then you also cut the right atrium. You close this area first because you don't want to cut into it will be difficult to reconstruct this area, and then you cut toward the tricuspid valve annulus, as you can see here, all the way till you see the fat in the back of the heart, and then you brought this back together, as you can see here, and then on the left side you resect the atrial appendage, then you sew it back together, then you cut the left atrial the pulmonary vein, and then you sew it back together, and then you cut to the mitral valve annulus and you sew it back together. There will be a lot of suture line here, you know. Then you close everything back. Okay? I don't think they will ask you about this. So let's go to the money. Okay. So history of development of atrial fibrillation surgery, beginning around 2000s, there is alternative energy sources developed and replicate the lesions of Cox Maze 3. They will ask you what are the available energy sources that you can create the lesion. You said unipolar radiofrequency, bipolar, laser, microwave, high intensity focused ultrasound, and cryothermia. This is an exam question. So what are the features of radiofrequency ablation? RF, it's produce thermal injuries by producing alternative currents between 100 to 1000 kilohertz. Unipolar pen or bipolar clamp. Unipolar RF can be applied from endocardial epicardial approach. It heats the atrial tissue up to 90 degrees Celsius. Bipolar RF deliver thermal injuries between the jaws of the clamp. Bipolar RF usually heats the tissue to 60 to 70 and needs 20 to 30 seconds to produce a transmural lesion. The main limitation of the bipolar RF, it can cause injuries to the coronaries and the valve tissues because of hyperthermic denaturation of the collagen. Cryothermia, it's produce tissue injury by forming an intracellular and extracellular ice crystals formation. We use two main gases, which is nitrous, which cool the tissue to minus 89 degrees Celsius, or argon, which cool the tissue to minus 81, 87 degrees Celsius. The size and the depth of the cryo lesion determined by numerous factors, which is the probe temperature, the tissue temperature, the probe size, the duration and number of ablation, the particular liquid used for cooling agents. Usually, and this is how I teach the resident, usually we need 3-minute application on the left side and 1 to 2 minute application on the right side. Cox Maze 4 procedure in the second decades, still it's gold standard. This paper come from Ralph Damiano. He's a very famous atrial fibrillation surgeon from St. Louis in Missouri. He actually works with Dr. James Cox. So if you look at the right atrium, okay, so they make a small, this is how he does this, okay? So the right atrial lesion set, you do, you cut here, you do the, you make a small hole, and then you make the right atrial body, and then you make a lesion to the coronary annulus, to the tricuspid annulus between the commissure of the anterior and septal. Then you go here and you make a lesion into the tricuspid annulus between the commissure of the posterior and anterior. You make SVC and IVC. On the left, you do the pulmonary isolation, and then from the left superior pulmonary vein from the atrial appendage to the superior pulmonary vein, you complete the box lesion by isolating the veins from this directions, and then you do the tricuspid valve annulus lesion. So this is how you use the clamp here. You can use a cryo here, and they use a clamp here and a clamp there, and then they use the clamp to complete the box lesion and the mitral annulus lesion. And the right, this is how they do the clamp for the right and left. So you basically dissect around the pulmonary veins, and you get the clamp to isolate the pulmonary vein. I mentioned this, and I keep telling all people who wants to do atrial fibrillation surgery, you have to be careful not to ablate the pulmonary vein himself, because you could end up with pulmonary stenosis, pulmonary vein stenosis. So you have to develop the Sangard groove and I think Kaitham knows what I'm doing, and then you have to ablate into the atrial tissue. On the right side, the same as we described. You make longitudinal arteriotomy, small hole here, right atrial bodies, SVC, IVC, and the tricuspid annulus lesion here and there. This is how does it look, and this is another important thing. Okay, so if you do it, minimally invasively, that means from the right thoracotomy, you can access the right vein, but you cannot access the left vein. So this you have to do to the cryo, but you can complete the box lesion with the clamp. You can use the clamp to the mitral annulus and the coronary sinus lesion. Then you use the clamp to do the right atrial body and the tricuspid valve annulus. But however, you need to use the cryothermia because you cannot access this from the right side. Then you use the cryo ablation, and then you do the SVC, IVC, and you do This is the line between the right atrial body. I mean, between the aortotomy to the tricuspid valve annulus. But if you do it through the sternotomy, things are different. So you can isolate left and right, continue the box lesion, do this, and then do this with the cryo. You do the right appendage with the clamp, and then you do the tricuspid annulus with cryo. This is your surgical incision, and then you do your SVC, IVC, and then you do your lesion here, which is the tricuspid valve annulus with a clamp. Okay, I want to share with you a video here. Just give me a second. Okay, this is how we do it robotically. So we do the first lesion, the coronary sinus lesion, from the epicardium of the heart toward the area of the P3. And we use the probe. See, you can see here, this is from the outside. Then we do we isolate the pulmonary vein from the edge of the left atrial body to the left atrial appendage with one application here. When you finish this, we do continue the isolation by coming from the upper border of the left atriotomy to below the appendage. You see here, to connect these two lines, okay? So you see here, this is the inferior veins. And after that, we finish by doing the mitral annulus lesion, which is the area corresponding to the same area of the coronary sinus lesion. That's why I marked where I finished my coronary sinus lesion. So because I want to correspond lesions, because I want to prevent what you call a typical atrial flutter of the left atrium. Then we open the right atrium, as we said, in the longitudinal fashion. We do the first lesion into the right, into the tricuspid valve annulus, and we have to give cardioplegia during this lesion because you want to prevent any injury to the right coronary artery. Then we do what we call SVC lesion from the lower border of the arteriotomy to the lateral wall of the SVC, and you avoid touching the SA node, and you avoid touching the phrenic nerve in this area. Then you do the right atrial body. This is a modified lesion. This you go from the upper border to the appendage, and finally you do your IVC lesion, which is from the arteriotomy all the way down to the IVC lateral wall, and you also have to watch for the phrenic nerve. After you finish this lesions, we close the right atrial appendage. This is how I do it in open and in the robotic technique. The guys who work with me, like Haytham, knows when I do imbrication, which I include the body of the left atrium with my closure because I want to prevent reopening of the appendage. Then you can go, you do either next layer the same way, or you could do as we're doing here, the transverse, just to get the tissue back together. Okay. After finishing the left atrial closure, the left atrial appendage closure, you close the left atrium with the single layer closure as usual when leaving LV vent, and you close the right atrium. Also, we do that robotically as well. So now we'll change the gear from surgical techniques into the most important things, the indications and the literature data about surgical ablation. So there's two important bodies that are responsible for this. This is AATS and STS. AATS guidelines does not focus into the indications, but it focuses mainly on efficacy and the safety of surgical ablation, prevention stroke in short and long term, and improve patient quality and short and long term survival. According to STS and STS guidelines, surgical ablation does not increase the post-operative morbidities. So ATS guidelines meta-analysis did not detect decreased transient ischemic stroke. ATS guidelines meta-analysis found improved quality of life. ATS guidelines show no improvement in 30-day survival with SA. They did not find improvement in long-term survival. So expert consensus guidelines examining the surgical ablation for atrial fibrillation. Neve, this is another surgeon. He's with Ralph Damiano. I trained with Vinay Badwar. This is all big names and Mark Glinov in surgical ablation. As you can see here, surgical ablation was associated with less perioperative pneumonia, so it's in favor of surgical ablation. This is frost plot for meta-analysis. So there was no increase in ICU length of stay with surgical ablation. There was no increase in hospital length of stay. So doing ablation does not increase your hospital stay, does not increase your ICU stay. It does not increase your hospital admission, and no increase with post-operative bleeding, and no increase with post-operative renal failure, no increase in perioperative stroke or TIA with SA, no difference in stroke prevention with meta-analysis. However, if you look at the randomized data, non-randomized data, they showed that there will be lower stroke incidence with surgical ablation. So indication for surgical ablation and expert consensus. So the STS guidelines, now we did not talk, so AATS guidelines did not talk about indication and it talks about mainly efficacy, safety, so to convince the people that doing surgical ablation, it will not increase their problems. However, STS guidelines focused in the indications. So, and they categorize it mainly into three main categories: surgical ablation, concomitant mitral surgery, surgical ablation in AVR and CABG, or standalone ablation. So this is the STS guidelines in 2017, written by Vinay Badwar and the rest of the group. And you can see here there is also the big names in ablation, which is Ralph Damiano, Glinov, and Nev 8 as well. So look, if you ask you about indications of okay, you have to be careful in the exam, because when you refer to a guidelines, you have to specify the guidelines. Because if you go to the HA guidelines that published in 2014, updated in 2017, there is no class 1 indication for surgical ablation. It's class 2A. But if you refer to STS guidelines, which is the main guidelines for atrial fibrillation surgery now, then this is class 1. Okay. So surgical ablation for atrial fibrillation can be performed without additional risk of operative mortality or major comorbidities, and is recommended at the time for concomitant mitral operation to restore sinus rhythm. This is class 1 level of evidence A. Surgical ablation for atrial fibrillation can be performed without additional operative risk, mortality, or major morbidity at the time of concomitant isolated AVR and isolated CABG, and AVR or CABG. And this is a class of evidence class indication 1, level of evidence B, non-randomized. Surgical ablation for symptomatic atrial fibrillation, absence of structural heart disease that is refractory to antiarrhythmic drugs and catheter-based therapy, both is reasonable as a primary standalone procedures to restore sinus rhythm. So if you go for standalone maze without structural heart problems, it's class 2A, level of evidence B, randomized. At the time of concomitant cardiac operation in patient with AFib, it's reasonable to surgically manage left atrial appendage. This is very important, because most of the data literature showed that if you close the left atrial appendage, if the patient have atrial fibrillation, you will have very good prevention from stroke. This is class 2, level of evidence C, expert opinion. Surgical ablation for symptomatic persistence or long-standing persistence atrial fibrillation in absence of structural heart disease is reasonable as a standalone procedure, Cox Maze 4. So this is another good, important recommendation. If you're dealing with persistence or long-standing persistence atrial fibrillation, you need to consider Cox Maze 4. You cannot do pulmonary venous isolation. Okay. Surgical ablation for symptomatic AFib and setting of left atrial enlargement more than 4.5 or more than moderate or more than moderate mitral regurgitation by pulmonary venous isolation alone is not recommended. It's reasonable to perform left atrial appendage excision or exclusion in conjunction with surgical ablations for atrial fibrillation to decrease the longitudinal thrombotic morbidity prevention. And atrial fibrillation should be treated as a multidisciplinary heart team. So what is the summary of this? So if the patient's coming for mitral valve surgery and he has atrial fibrillation, it's class 1. If the patient coming for CABG and AVR or CABG AVR and he has atrial fibrillation, it's class 1. If the patient coming for standalone maze, it's class 2A. If the patient have, you're not going to do maze and you have atrial fibrillation, closing left atrial appendage is class 2A. If the patient coming with long-standing persistent atrial fibrillation, you should do a Cox Maze 4 class 2A. And you should not attempt pulmonary venous isolation of the left atrial size more than 4.5, because I keep asked these questions from different trainees. Is your left atrial size important? Yes, it's important, but and when you do Cox Maze 4, it's actually even you can go up to 7-8 centimeter size of atrium, and you could still get a very good result. But if you do pulmonary venous isolation, this should not be considered if the size more than 4.5. So surgical ablation with mitral valve surgery, mitral valve by itself disease has a very big association with atrial fibrillation and atrial arrhythmias. Most of the data in the literature are derived from this concomitant with mitral surgery. Mitral valve surgery by default involving opening the left atrium, so the decision to do ablation, it's a bit easier. A pathological mitral valve is often associated with the left atrial enlargement. Surgical ablation is prone to fail, especially if you do only PVI, as I said before. Initial thought process that doing surgical ablation will increase the complexity of the case, and this will reflect an increased mortality and morbidity. However, multiple guidelines and multiple observational and propensity match retrospective studies does not show this association, as I showed you before with the AATS guidelines. The surgical ablation with mitral valve surgery, the favorable impact on survival, could relate to, and this might be an exam question, why they improve survival? Because it's increased the left ventricular function, decreased the left atrial size, and substantially decreased the stroke rate with successful management of the left atrial appendage. This is a paper came from Scott Rankins, and also the senior author was also Vinay Badwar, an association between the surgical ablation and operative mortality after mitral valve surgery, and it showed that clearly with atrial fibrillation at time of the mitral operation, it associated with a lower adjusted risk operative mortality, as you can see here. If you look at the operative mortality, if you have group 1, which is no atrial fibrillation, no surgical ablation, if the patient have atrial fibrillation, no surgical ablation, if they have atrial fibrillation and surgical ablation, so the mortality is comparable with mortality if the patient have no atrial fibrillation, and it's significantly lower than the patient if they have atrial fibrillation and you did not do the surgical ablation. Long-term outcome following concomitant mitral valve surgery, Cox Maze 4 procedure, again, NIV8. So here you show the presence of the percent of patient with the sinus rhythm and off antiarrhythmic drug. So this patient in sinus rhythm on antiarrhythmic, this is off without antiarrhythmic, and they follow them up to 84 months. And you can see that they have sinus rhythm up to 66% with antiarrhythmic and 55% without antiarrhythmic at 84 months. So they did a mixed module logistic regression analysis for the recurrence of atrial fibrillation. So they found the most important thing is the duration of atrial fibrillation. If the patient have long-standing AFib for a long time, they're prone to have a recurrence of atrial fibrillation. It depends also on the surgeon experience. So if the surgeon is expert in this procedure, they will have a better outcome. And cryothermia only associated with higher recurrence rate. However, this is in his study, but in multiple other studies showed that the cryothermia is as effective as radiofrequency. It's actually sometimes better. So he could see the freedom from embolic stroke with up to 84 months was 96.6%. AVR and CABG, concomitant AFib in context of AR and CABG is indicator that the patient have advanced comorbidities. AFib patient undergo AVR without surgical ablation should increase operative mortality and decrease long-term survival. Some surgeons prefer to use a less invasive approach. That's why they use the BVI. BVI demonstrates promising result if the patient have paroxysmal, as I said before. However, if the patient have long-standing persistence, they have a very high, only 59% they can maintain into sinus rhythm with BVI. The higher rate of death is associated because of left atrial enlargement, as I said before, and duration of atrial fibrillation. Overall, the success of BVI and AVR on CABG range between 50 to 80%. However, the successful rate of the Cox Maze 4 is about 90%. So that's why I'm very advocate to do Cox Maze 4 for AVR and for CABG. 1 year mortality cost associated with the surgical ablation for atrial fibrillation concomitant with coronary artery bypass operation. You can see here that if the patient goes with CABG or CABG with ablation, that the patient survival or probability of death is lower if the patient goes with ablation operation. Long-term safety and efficacy for concomitant Cox Maze procedure for atrial fibrillation in patient without mitral valve surgery. As you can see here, they have a very good result to maintain sinus rhythm up to 5 years, and most associated operation was the CABG. Standalone, this is a very controversial, but it's indicated when the patient have failed medical therapy or failed previous catheterization, long-standing persistent defibrillation. They should not do. This is another indication for standalone Maze, or the patient intolerant for oral anticoagulant. The STS database operative mortality for standalone Maze is very low, 7.74%. Most of the data literature derived from many invasive approach. So AATS guidelines divided the minimally invasive approach or off pump into 3 categories: bilateral mini thoracotomies or thoracoscopic bipolar, RF, BVI, and left atrial management, with or without additional lesions in left or right, or unilateral right thoracoscopic posterior encircling isolation box lesion with suction assisted bipolar unipolar RF without left atrial appendage management, or which you call posterior LA wall epicardial ablation with pericardoscopic detect vacuum assisted, and this is what you call a conversion procedure without management of the left atrial appendage. So it relies on concomitant catheter ablation. When we say it, a hybrid technique, it's a concomitant catheter ablation to complete the isolation of the pulmonary vein as well as cavo-tricuspid azimuth lesion. The hybrid ablation using surgical epicardial followed by catheter endocardial approach. Well, this will be done within 6 months. Early result is promising for paroxysmal. However, for persistence, long-standing persistence is very poor. This is Alamier. It's from Belgium. He's very big name in the thoracoscopic hybrid approach. As you can see here, they show that the patient, according to their 17 patients, persistent atrial fibrillation is better than paroxysmal. I don't think we can make a conclusion out of this because it's a small number, and they have 4%. The 4 patients they have a recurrence rate. Also, again, a paper for treatment of lone atrial fibrillation as a result of hybrid employing greater frequency. You can see that if you do a hybrid and non-hybrid, you can see that AFib prevalence with hybrid initially higher, but then the hybrid is better than the non-hybrid. And he showed that the hybrid with the paroxysmal have a better result than long-standing persistence. My midterm outcome for concomitant thoracoscopic epicardial and transcatheter and long-standing persistence. Again, he showed if you persistence or long-standing persistence, look at 30 months, the only successful rate was about 60%. Now, if we talk about hybrid epicardial endocardial ablation using a pericardoscopic, which you call as a conversion technique. Again, the freedom from atrial fibrillation at 400 days was also low. The problem with this technique, first of all, you don't treat the left atrial appendage, and you can end up with very devastated major complication, which is there is one patient who developed atrioesophageal fistula, and one patient have a sudden cardiac death. So in my opinion, this procedure is successful rate does not reach up to 55%, and it might associate with very devastating complications. So I don't recommend this. So long-term success of the convergent atrial fibrillation. So according to these people, at 48 months, they have a patient on sinus rhythm without antiarrhythmic drug at 69%. This very important paper came from Cleveland Clinic with Mark Gilinov, when he looked into the surgical ablation for atrial fibrillation during mitral valve surgery. This paper also confused a lot of people, because first of all, if you have a mitral valve patient with atrial fibrillation, if you do ablation, you have better sinus rhythm. Then he compare if you do by atrial maze versus BVI, and they showed no difference. And but however, in their subsequent presentations, they showed in the paper that it's actually by atrial maze was associated with better freedom from atrial fibrillation. By atrial maze procedure versus pulmonary vein isolation for atrial fibrillation during mitral valve surgery, new analytical approach. This is the paper I'm talking about. You see here. So if you have a BVI only, you have a very recurrence of AFib. But if you have patient with biatrial maze, they have a better outcome. So this is the subsequent paper that they correct their mistake at the first paper. Meta-analysis comparing left side atrial ablation versus biatrial ablation. According to this meta-analysis, there was no difference in maintaining sinus rhythm at discharge and at the 6 month. There was no difference in terms of CVA. Biatrial associated with higher need of pacemaker than left-sided ablation. Left atrial versus biatrial lesion for resistance atrial fibrillation during open heart surgery. As you can see here, if you do a biatrial, it's associated with better freedom from atrial fibrillation. However, it is associated with higher risk of sinus node dysfunction and pulmonary and permanent pacemaker need. However, you have to be very vigilant about the ablation of SVC and right atrial body, so you don't cause SA node dysfunction. This is a paper about late outcome procedure of Cox Maze 4. As you can see here, the freedom from atrial fibrillation at 1 year was 93%, at 5 years 78%. If you compare paroxysmal with non-paroxysmal, they actually comparable at 5 years. And they found the probability of you to go back into arrhythmias or to have antiarrhythmic drug is the duration of preoperative atrial fibrillation. So if the preoperative atrial fibrillation long, you have a very high probability that you're going to go back in atrial fibrillation. This is a paper looked into the survival benefit of patients with going cardiac surgery who have Cox Maze 4. As you can see here, if the patient have untreated atrial fibrillation, they have a worse overall survival, and it was actually statistically significant. However, if you compare the patient with no atrial fibrillation with Cox Maze 4, they have a comparable survival. So this paper by Farha Musharbish and Dr. Ralph Damiano from St. Louis, Missouri, showed clearly that the patient with Cox Maze 4, they will have a better survival. And again, if you compare no AF with untreated AFib, they have the patient with untreated AFib, they have a worse survival than the regular population. And there was a patient with non-paroxysmal atrial fibrillation, they have worse survival than the patient with the paroxysmal atrial fibrillation. Now, surgical ablation for atrial fibrillation in the United States, trends and propensity match score. This is a paper published also by Vinay Badwar. Most common procedure is mitral valve with ablation, followed by CABG, AVR CABG. You can see the standalone is still low and will continue to be low. Mortality, it was lower with ablation, as you can see here, if you have no ablation, and it was statistically significant. Stroke was lower in ablation than non-ablation. However, renal failure was higher in the ablation group, need of pacemaker was higher in the ablation group, and prolonged ventilation was longer on non-ablation group. Readmission was higher in the ablation group, but this is because sometimes a patient with ablation, they have a fluid retention, they require more lasers. Sometimes they come to with fluid retention that you need to admit them to the hospital. So surgical management for left atrial appendage. The obliteration of left atrial appendage at the time of the SA has been shown to improve the outcome. The exclusion for left atrial appendage can be achieved by stapling, clipping, or the double layer closure I showed you in the videos. LA stapling may associate with a poor outcome, and it can cause residual stump. So this is a paper came from Patrick McCarthy from Northwestern University in Chicago. They tried 3 techniques. It's internal ligation, stapled, or surgical excision. They have a very failure rate was high, so you can make a conclusion out of this paper. However, does left atrial appendage ligation during coronary arrest decrease the incidence of postoperative stroke? According to this paper, they did not found any no significant reduction in postoperative complication was achieved with LA ligation. However, excision of left atrial appendage with novel device, which is the atrial clip, was done and showed very promising result. That the successful rate up to 3 months was up to 98%. And as you can see here, this is pre-operative, post-operative. The appendage is clipped, and you can see it here. And after surgery, you can see here the atrial clip. You see it here, and then it's obliterated. Sometimes doing LA appendage is not easy. Sometimes you can end up with fatal complication. Like this paper, they presented the patient have a massive air embolism and ended up with stroke and died, or patient have bleeding and died with bleeding. However, a JAMA paper came recently in 2019 looking into the association between left atrial appendage occlusion and readmission for thromboembolic stroke. And if you do left atrial appendage closure, it's associated with less risk of stroke, was associated also with better all-cause mortality, and was also if you combined stroke and death, it also was better if you close the left atrial appendage. Last thing, the guys who trained with me here, they know that when I do Cox Maze 4 and I put the patient in sinus rhythm, I don't anticoagulation post-op, because this paper came from West Virginia, where I trained with Dr. Badwar. And you can see here that they follow their patient, return to normal sinus rhythm, were actually very good. And the risk of stroke without anticoagulation was 97.5%, which is very low. And they got to only 2 stroke, and this was actually hemorrhagic, non-embolic. So there's no need for anticoagulation. So the take-home message for you today, the epidemic is AF is increasing. Surgical management of AF was started back in the 80s by Dr. James Cox, and eventually it evolved to Cox Maze 4. And this is the standard of care for surgical ablation in 2000s. Cox Maze 4 has the best result to restoring sinus rhythm. ATS guideline focus on safety. SDS guideline focus on practice and guidelines for surgical treatment. Concomitant AFib with mitral surgery has the highest rate of sinus ablation or surgical ablation. Minimally invasive ablation hybrid approach had a good role in paroxysmal, however, result in long standing is not good. Mitral valve with the paroxysmal atrial fibrillation can be managed with left maze, however, biatrial maze has better restoration of sinus rhythm. Mitral valve with long standing persistence should be treated by atrial maze. CABG, AVR, other cardiac operation with the paroxysmal atrial fibrillation can be managed with BVI, LA occlusion, with success rate around 70, however, biatrial maze has a better restoration of sinus rhythm. CABG, AVR with other cardiac operation with long-standing persistence should be treated with biatrial maze. Cox Maze 4 LA should be closed. Cox Maze 4 did not associate with increased mortality or morbidity. Cox Maze 4 can be discharged without anticoagulation. Closure of left atrial appendage is reasonable in patient undergoing cardiac surgery without history of AFib. With history of AFib without maze, arrhythmia surgery need special training. Thank you. Guys?
Thank you very much.
Thank you, Doctor.
A lot of information.
Doctor, I wanted to ask one question. So what is the trend now if I'm going for a mitral valve replacement, for example, with chronic long-standing AF? Would I still proceed with the Cox Maze 4, as you mentioned? Is that the current trend
Any patients come to my OR table going for mitral valve, has atrial fibrillation, I always do Cox Maze 4, unless if it's technically difficult, like I did last case, I did mitral valve, his atrium was 10 centimeter. Even if I use Cox Maze 4 cryoprobe, I will not be able to isolate because it's huge. So that, yes, I give up, but you can ask Haytham. He's any patient comes with mitral valve, with atrial fibrillation, I always do Cox Maze 4. But maybe I'm biased because I love to do this operation, but yes.
I see. Excuse my ignorance, but how are the results with chronic AFib? Do they usually revert and benefit from surgery? I'm not aware of that.
I will show you a study I presented in New York. Cox, okay. You see this? Do you see this slide?
Yes, Dr. Kaplan-Meier's curve, yeah.
So this is robotic cryo Cox Maze, and we have a 90% freedom from atrial fibrillation at 2 years. 90%.
All of these were long-standing chronic AF?
70% of them long-standing persistence.
MashaAllah.
And kindly, Dr. Mohammed, what was the number of the patient on this study?
50 patients.
Oh, good number.
We included 50 patients.
50.
Yes.
Okay.
So guys, we'll take a break for till 4:30, and then we'll have half an hour to 1 hour. I have some questions for you, mock exam, and the topics we discussed today. Okay.
Okay.
Sounds good?
Yeah, excellent. Shukran.
Haytham, please send me the link to my other phone because this phone is going to die. Okay.
Okay.
Thank you. She had, when she came, she was complaining from mild fever, and when they did blood work, they found also a mildly elevated white blood cell counts. She also reported some weight loss. So please tell me how you will approach this case.
Okay. First of all, I will go to see the patient. Then I will introduce myself to the patient. Then I will start asking her about her symptoms, when exactly her symptoms of feeling unwell started.
6 months.
So 6 months. It was progressive with time?
Yes.
Okay, so the symptoms that she had is fatigue, any shortness of breath?
She has some shortness of breath, New York Association class 2, fatigue.
Fatigue, and that shortness of breath, it doesn't increase with the time. Progressive, I mean.
Okay. She said sometimes she feels short of breath when she walks to the washroom, but most of the time it's okay.
Okay, and any chest pain?
No chest pain.
No chest pain. Any shortness of breath, no chest pain. Then I will ask her if she had any feeling of palpitation.
Yes, she feels palpitation, and her EKG showed atrial fibrillation.
Atrial fibrillation, and before that, before this 6 months, before this new events, there was no atrial fibrillation with her, or palpitation, history of palpitation. So new onset.
She does not know. This is the first time she showed the emergency room, and EKG showed atrial fibrillation.
Okay, and I will ask her about her comorbidity, if she has any diabetes, any thyroid.
She's 40. She has no problems.
So medically free, surgically, any surgical history with her?
No.
Okay, any family history of cardiac disease?
No.
When she was child, she have a history of fever with sore throat and joint involvement or joint pain and swelling?
No.
No as well, and no family history, and any history of loss of consciousness?
No.
Okay.
So proceed to physical exam. Don't waste your time, you know. Let's go.
Okay, physical examination. I will listen to neurologically.
Okay,
I will examine her neurologically and
okay, so I'll give you a quick exam. So she's a mid-built lady. She does not look in stress. Her temperature was 37.8, 37.9. Lung was clear. Cardiovascular exam showed S1 plus S2. There was abnormal sound. We're not sure if it's S3 or any other sounds. Her GVB was okay. She does not have lower limb edema, and pulse was irregular. Abdominal exam soft and lax, no abdominal distension. Bowel sounds are good. Joint exam was normal.
Okay.
So what you want to do?
Okay. After examination, I will go for investigation for her.
Okay. So her lab was all normal range except for white blood cell count is 13.
13, and I have abnormal heart sound with this. She's free. I will see the hair X-ray also if any congestion in the lung, and I need to order echo for her.
So chest X-ray was done. It showed a little bit of congestion, but it's not significant. And cardiac border was normal.
Okay, no calcification. Okay,
so you want to get an echo?
Yes. The next one is echo.
Okay, so echo showed a huge mass on the left atrium. And sometimes this mass goes across the mitral valve, and sometimes it obstructs the LVOT. So what do you want to do now?
Okay, this from history, physical examination, and echo finding. What is the characteristic of this mass? And I need to review the echo itself. I need to see
sorry,
the
I don't have. Sorry, I would like to show you images.
Okay.
Let me see if I can show you some images. Just a second. Bear with me, okay?
Yes.
The video. Okay, معلش, okay. Okay, let's assume this is the mass, okay? You see the mass?
No, I see nothing.
You don't see? Okay, let me share the screen. I'm sorry. I did not share the screen. Sorry.
Okay.
You see it now?
Yes.
Okay, let's assume this is the left side, not on the right side. Right? So what do you think?
So this is a huge, this is a apical 4-chamber view, the transthoracic echo, which showed a huge mobile echogenetic mass that attached to this one, to the lateral wall of the LA, and it's
Protruding through?
Protruding through, this is in the right side.
I know, but I said let's assume. I don't have the image for that now.
Sorry, Shane. My mind. Okay.
Just for you,
protruding to the through mitral valve.
Okay. So what do you think about this mass?
So this mass, along with the history and characteristic of this
you
mass,
have to be
most likely
in the exam. You have to be fast. You cannot like spend 5 minutes prescribing an echo. You say this is attached to the interatrial septum.
Hello.
Is اسمعني؟ الو
ايوه
اسمعني ولا لا؟
ايه الحين بس اسمع.
In the exam, you cannot spend more than a lot of time. So you say this is a mass attached to the interatrial septum, protruding through the mitral with multiple echogenicity, most likely left atrial myxoma. Quickly, you don't. You have to be very confident, and you have to be up to the point. Okay. So what do you want to do next? الو هيثم.
سامعينك بس الظاهر هيثم النت عنده في مشكلة.
Okay, somebody continue the case, please.
I will.
Go ahead.
If she is vitally stable, I need further imaging,
Like
just to CT or MRI, and I prefer MRI.
Why?
To see if there is any extension of the tumor in the heart wall or outside the heart.
Okay. Okay. So we don't have any in your hospital. There is no MRI available.
So we'll go with CT or let's do TE first. If she is vitally stable, then we can do CT.
Okay, you got CT scan was done, and it showed there is nothing extracardiac.
So this patient her diagnosis is atrial myxoma, and she is at risk of obstruction due to large and mobile mass protrude to the left ventricle, and with complication stroke. So I will stratify her for risk of surgery, get CT scan as a baseline because she developed stroke before, right?
She had a history of seizure before.
Seizure,
but she should not have a history of stroke.
So I will stratify her.
Do you need to do any further workup before you go for surgery? She's 40 years old.
Yeah. Coronary angio.
Okay, coronary angio is done and it's normal. So what's your plan?
My plan to take this patient for surgery in urgent base because her presentation and the size and presentation of the mass.
Okay. So
I will be in OR before induction.
The patient in the operating room now. What you will do?
This patient high risk to collapse during induction of anesthesia. So I will prepare the pump, make sure everybody in the room and ready, and I will be there, and I will prep her, and then I will be ready to prep her once they intubate her.
Okay.
Then I will go with median sternotomy, bicaval cannulation. This is the left side. Bicaval cannulation, and I will try to not manipulate the heart before cross clamp. I will not put a vent through the left, as I usually do, through the left, through the right superior pulmonary vein. I will vent from the root. I will do this case bilateral approach. I will open the after snaring. I will and snaring after cross clamp cardioplegia snaring. I will open the left and right atrium see the mass exactly, see the important structure around it. Then I will start small incision and resect all the mass with a free margin of 5 millimeter, and send that mass to histopathology and reassess the left and right side, wash and reassess the mitral, and close the defect with a batch. And
Okay.
sorry, I missed something. I missed something.
Go.
And I will do Maze for this patient as well.
So you will consider Maze in this patient?
Yes, she's atrial fibrillation, right?
So what you will do? What kind of Maze? When you say Maze, Maze is the general term. Give me specific Maze. What kind of Maze you will do?
Depend if she is paroxysmal or base.
No, her echo. She came to the hospital, to ER. She is in atrial fibrillation. She stayed in, and now we take her to ER, and she's still in atrial fibrillation. But we don't know what's her back history.
We don't know them. So the most effective in her situation will be, or say it's Cox Maze 4. I will do the all lesion with. Unfortunately, I didn't see the cryotherapy. I saw and trained to do the lesion on radio frequency unipolar.
Okay, that's fine. Okay, so we're not gonna go. So you want to do it with you? Okay, so are you gonna close the left atrial appendage or not?
Yes. Yes. If I'm not doing Maze, at least I will close the appendage and do pulmonary vein isolation.
Okay. How are you gonna close the left atrial appendage?
There is different way to do, but the way I train on to close the appendage with interrupted U-shape suture, and there is other way to do bear string, do bear string and put it back again. I saw some technique, but I'm not comfortable to do it, which close the appendage from outside with silk tie.
Okay. So now you finish the surgery, you close the patient, and the patient is transferred to the CVICU. In CVICU, she was doing fine, but the nurse called you. She said her right leg is cold. So what's your differential, and what you want to do?
The top one of the differential will be the leg ischemia due to mobilization of the mass.
So what do you mean leg ischemia due to mobilization of the mass?
Embolization, part of the embolism.
Embolic event to the leg causes ischemia. Okay, yes. That's good. Okay, what other differential?
Could be cold leg. Could be.
No, the other leg is normal. The right
the
leg
other leg is normal. It's less likely to be dissection through due to the cannulation.
Excellent. You have to mention a dissection. So what are you going to do to confirm either dissection or embolic? What are you going to do?
I will do TEE for her since she is still intubated.
Okay, TEE is done. You see nothing. Your repair is good, and there is no mass in the cardiac, the heart. Now the leg is more ischemic.
I will consult my colleague in vascular, and we will do Doppler for her. And if she is Doppler
is done. Vascular came, Doppler is done, and Doppler showed there is no flow on the common femoral SFA and profound. There is no flow.
So this patient, we need to revascularize her leg and do it.
Yeah, but you mentioned she might have a dissection. So how you confirm a dissection?
Yeah, we did.
Yeah, T is done. They're not sure. They don't know if there is flap or not.
They don't know.
It's non-conclusive.
We can do CT angio, but that will take time.
Excellent. You send her for CT. There is no dissection, and there is occlusion of the. How you manage this?
Thrombectomy.
Thrombectomy, excellent. The vascular, take care and do thrombectomy. Thank you. You passed the case.
Thank you.
Okay. Who wants to do the second case?
Now I'm back actually. Sorry, the internet, there was a problem. I came with my
You're
mobile.
back, but, okay, that's fine. Who wants to do the second case, guys?
I can.
You can. Okay,
Let's
good.
see.
Me too. Hello?
Like دقيقة بس 1 second.
دقيقة.
You see the screen now? Hello?
Yes, clear.
Okay, so we called you from the ER. This is a 60 years old guy who had a history of cabbage times 3 10 years ago. He presented with dizziness and presyncope in a golf course. He came with ER with this EKG. So can you look at the EKG and tell me what you see? Who's doing the case?
هيثم.
Who's doing the case?
هيثم بس I think انه انفصل عنده النت مرة ثانية.
طيب يلا. Somebody else. Not اللي سوى
Hello. No, now it's okay. So complete.
So
this is a complete heart block.
Complete heart block. طيب.
Dissociation in the B.
So what you want to do, Haytham?
So complete heart block. I need to know why he has a complete heart block. So he had a presyncope, which is explained by his.
I ask you questions. I did not say what you don't need to know. What you want to do? Be specific. Patient's complete heart block, dizzy, he's presyncopal. What do you want to do?
Pacing for him.
So what kind of pacing? You have to be very specific.
Okay, so I need to call the cath lab for temporary transvenous pacing.
Excellent. Temporary transvenous pacing. Excellent. So that's good. So temporary transvenous pacing. طيب ممتاز. Okay. You lost the screen, صح?
No, I can't see your screen. You are in the
Okay,
internet actually.
How I'm going to stop sharing now? How you stop sharing here?
Go to share screen and click on it. There is a button saying stop sharing. Let me do it.
تحت هتشوفه في الجوال عندك دكتور.
لا بس انا على الكمبيوتر معلش. ستوب شيرنج يا هيثم ستوب شيرنج. اوه هي خلاص.
سويت لك هي.
طيب اوكي give me a second now just wait. I'm sorry guys لان عندنا technical issues هنا معلش سامحونا شوي.
No, it's okay.
Where's Zoom? You see my screen now?
Yes.
So next day, Haytham, you see this EKG. What's this EKG?
Junctional. This.
Just read it well. It might be small.
Okay. So B wave. This is this one. This is a BVC. BVC, another one. It's still, it seems like complete heart block with the BVCs.
This is the type 2 second degree AV block, okay? So what do you want to do now? He still has a temporary pacing.
Okay, this second degree, second degree, that mean there is an indication for permanent ICD for this patient, but why? This is an indication, but we need to know why he having this. Is it ischemic in nature? I need echo. I need to. He's status post cabbage. I need to do cath.
I ask you a question. This is second degree AV block. Why you want to do? Why you want to put an ICD?
Sorry, permanent pacemaker.
He needs a permanent pacemaker. So who's gonna do the permanent pacemaker?
I will ask my cardiologist colleague.
So before you call your cardiology, you need to do some workup. What are the workup you need to do?
I need to have EKG. I need also to have cath for this patient.
EKG showed
Sorry,
Yeah,
echo.
echo is normal ejection fraction, cath no, a normal patent graft, and EKG showed the morbid type 2. So what do you want to do?
Chest X-ray and lab, just the baseline.
Labs is normal. X-ray is okay.
Lab is normal. X-ray is okay. Cardiac is okay. He's a 70-year-old. You said in the beginning.
6-0.
6-0. So after that, I will consult the AP for him for permanent pacemaker insertion.
So I am the AP. You called me. I said, okay, Dr. Haytham, what kind of pacemaker you want for this guy? You did not expect this question, right?
Okay, and kind of pacemaker, and okay, there is the AB. What I know, there is a two kind of pacemaker. Either the what they call it with wire or wireless Macra. The new pacemaker.
Stop. So I don't want to hear about Macra on the exam, okay? Do not mention anything about Macra, okay? So when we say what kind of pacemaker you want,
ventricular
atrial or ventricular or
atrial or ventricular. Okay.
معلش شباب خلوا leave him خليه I'm talking.
Sorry.
So it's either single chamber or dual chamber, صح?
Yes.
So give me the 3 letters for pacemaker. And I did not explain to you pacemaker today, but this is part of the exam. You might ask about
so there is a 4 letters in the pacemaker. For example, DDDR, D dual.
What's
D
the first
dual?
letter
Yes,
for?
sensing, pacing, and inhibitor. The 4th one, if I want to add it for stimulus.
So first letter is sensing.
Second
letter is pacing. Third
pacing,
letter is
the inhibitor.
Inhibiting
response.
Or initiating.
Initiating.
Fourth, this is what we call it. If the pacemaker is actually sensitive for the patient's increased cardiac output, so he needs to increase the rating, right?
Yes.
Okay. So what kind of pacemaker you need for this patient?
The best complete heart block, atrioventricular.
So you want dual chamber pacemaker?
Dual chamber pacemaker, yes.
Okay, my question to you, can we put a VVI on him? And what's VVI?
VVI is a ventricular pacemaker on the RV. Yeah, we can do VVI for him.
So is VVI a wrong option or it's a valid option?
No, it's also a valid option because still he has the PO.
So what are the problem might happen if we put the patient in VVI?
The better physiological pacing for any patient is atrioventricular pacing.
I ask you specific questions. What are the problems might happen if you have a VVI?
I didn't recall.
So what happens if you put the patient only ventricular pacemaker? What do you lose?
They lose atrial kick.
They lose the atrial kick, so they can develop something called a pacemaker syndrome. What's pacemaker syndrome?
Okay, it is a cardiomyopathy. It's a cardiomyopathy related, caused by the pacing syndrome, the pacing itself.
Okay. So what happened is that you pace the ventricle in discordant with atrium. So the atrium can contract in a closed ventricle, right? And the patient can drop their output and they can drop their pressure with VVI pacing. However, when do you consider VVI pacing?
I'm not sure.
If the patient atrial fibrillation.
Yes.
Okay.
Yes.
Right. Now I'm a AP. I'm asking you what about VDI? What's VDI? Can you explain for me what's VDI?
VDI. Okay. Ventricular sensing. VDI. Ventricular sensing ventricle. pacing atrium and ventricle and inhibiting both.
So is this appropriate for this patient?
Yes.
No. Why?
He's not.
Because you're not sensing the atria. So this is
But
very
I'm
important.
basic.
It does not matter if you base, but because you can base atria, depends on the rate you put. So if you put a rate of 80 and the atria is going at 90, you're still gonna pace, right?
Okay, I will create a problem.
It can't create a problem. So when you do a dual chamber pacemaker, what do you like to do?
Dual chamber pacemaker.
And I got like VDI. That means I'm sensing the ventricle, basing both.
Yes.
I'm inhibiting. So I'm not sensing the atria. I don't know if the atria, how the atria is going. صح ولا لا?
Yes.
So what's the preferred mode for this patient?
The preferred mode is DDI.
DDD. Right?
Yes, DDD, yes.
DDDR, which is sensing both, basing both, inhibiting and initiating, and responsive for the patient movement. طيب. Now
But
we take the patient to
the R, I have a question because
I'm going to ask you questions.
Okay.
What are the response that you can monitor to increase the output of the pacemaker?
The tachycardia, the heart rate, no, how come sorry. Respiratory rate, one. The other thing they use
so one patient movement, right? Okay.
Yeah, one patient movement and one from the carotid.
Anybody can help Haytham?
Jugular.
Anybody can help Haytham? What are the response we use in the pacemaker?
Body movement.
Body movement.
Yeah.
What else?
And and the diaphragm movement.
No, خلاص. Body movement one. What else?
Respiratory.
Respiratory rate. طيب غيره. RV stroke volume, QT interval, central oxygen saturation. All this can be used as a sensor for the pacemaker. طيب. Now the patient's taken to the cath lab to do the pacemaker. Okay. So the AP, they did the atrial wire, so it went fine. He was doing the RV and he think that the RV lead is outside the heart. He called you. So what you want to do?
Okay, first thing I need to do urgent echo to check for if there is any pericardial. If you see the hemodynamic of the patient one.
First of all, before you jump in echo, you go, how is the hemodynamics of the patient? Before you jump in echo.
Yes, hemodynamic of the patient.
80, his heart rate is 70 V-base via temporary pacers. His blood pressure is okay, like in the 110. And he is comfortable, the patient. He's breathing and he's in face mask, satting 98%. He's not tachycardic, he's not tachypneic.
Okay, I want to see the image, the image of the cath, the same image. Why my EP colleague thinking he's perforating the RV? I need to ask him this question.
Okay, the lead looks like it's actually outside the heart in the pericardial space.
Okay, so at this time, if he can inject any contrast, just to see, keep the lead on his place, not to move it, just to inject the contrast, just to check if there is any extravasation or not, while we are in the cath lab.
Okay, he inject, there is no extravasation. We don't do this step, but it's okay. I'll go with you. Okay, we inject, there is no extravasation. So what you want to do? He's asking you if he can pull the leads out or not. What you will tell him?
Yes, he can pull it, but I need an echo in the
echo
in the room.
Done. There is trace pericardial effusion. Almost nothing. So you want him to build the pacemaker?
Yes.
Okay. So he said, okay, thank you. He built the pacemaker. 5 minutes later, the patient is crashing. His pressure is 30, and patient lost his consciousness, and the activating code blue. What do you want to do?
Urgent pericardiocentesis under echo.
They're trying to do that,
Guidance.
but it's infeasible because they're doing chest compression. Patient is almost, there's no pressure.
So I need to. That means he's in cardiac tamponade. I need to do urgent sternotomy
Where are you gonna do this? In the cath lab?
No, shifting him quickly to the operating room and open the chest.
Okay, so they try to shift him to the operating room. There's no blood pressure. They're still doing chest compression. What do you want to do? They cannot shift him to the OR. He's not stable. He's crashing. He's crashed already.
I will. Okay, if he's crashing, I will put him on ECMO.
Okay, how are you gonna do ECMO?
Peripheral ECMO on him.
How you do peripheral ECMO?
Okay, I will. In the femoral artery and femoral vein. There is no pressure.
Down,
so
you're gonna do percutaneous. What are you gonna do?
Percutaneous.
Okay, you're trying to thread the wire. You cannot thread the wire. CPR has been going on for almost now 20 minutes. Patient is dead.
I supposed to open him in.
Patient is dead. So you clearly went the wrong pathway. Okay. So I take you from a very simple case. This is exactly what I did like you. When I was in your shoes, I did the same exactly like you. I was in a review course. They asked me the same questions, and the patient's dead. So let's go back a little bit. So they perforated the RV. Yes, go ahead.
Yeah, and the first time when the cardiologist perforates the RV, he should keep the pacemaker and the wire inside. And I will, because patient at this time is stable, I will take him to OR in stable condition, and I will pull them the pacemaker under my according to my judgment. Should I pull it with cardiopulmonary bypass or no need for cardiopulmonary bypass? Most likely, this patient he will not need cardiopulmonary bypass. If it's small hole, we will just pull it and close the control bleeding with the direct batch if it's away from important structure.
Right, okay.
And the second scenario.
Okay, just let me tell you something. Okay. So first of all, if the patient is stable, so first of all, you ask this patient to be intubated right away in the cath lab. Okay. So they intubate the patient. So let's go sequence. Before you jump, I'm judge. Okay. Second of all, you ask your OR team to come to the cath lab. طيب.
Okay.
What are you gonna do for next? Patient is intubated. You prep and drape the chest. Are you gonna open the sternum?
And in cath lab or in OR, you mean?
In the cath lab.
No, this patient's stable. I will take depend on in my OR. If it's far away from the cath lab, I can if he's stable, even if it's far away, I will take him to OR.
So,
and in some hospital it's just the OR. It's next door to the cath lab.
So okay, so patient's intubated. You transfer him to your OR. Okay, the patient on OR table now. What you will do?
I will prepare blood for him for sure and make it ready in OR.
Everything is ready. So what do you want to do now? Patient is intubated, anesthesia is ready. You prep.
I will do sternotomy. and I will build the basic undervision.
Okay, nobody will mistake you to do sternotomy, but I won't do sternotomy in this case. What I will do subxiphoid window. Okay, first, because most of the time, why I let this patient die, because I want to see that you're safe. Most of the time, you don't need to do sternotomy in these cases because this hole is very small, and you take him to the OR. This is in the exam scenarios. You do subxiphoid window, you pull the wire, and you watch the patient. If there is bleeding, you continue your sternotomy. If there's no bleeding and everything is good, you put a chest drain and you close. Okay, guys?
Okay.
Okay.
And next scenario, I think, next scenario, we have to open him in the cath lab, right?
Okay, this is different. If the patient, they perforate and the patient is unstable, then you have to intubate him, prep and drape, open the cath lab. This is different. But if the patient is stable, you tell the cardiologist, please stop, don't do anything, intubate the patient, or even take him to the OR, intubate him in the operating room, and then do the subxiphoid window, pull the wire under direct vision. If there is no bleeding, good and well. You put a drain, and then the patient goes to ICU, and next day he can go for another attempt of pacemaker. Okay, guys?
Okay.
So I'm sorry, I have to take you through this case. I know they might quote you very easily in the OR, in the exam.
I never think of this scenario.
Right. I have a lot of scenarios, but I think it's 5:30 now, and we did two mocks. We can do something later on, guys. If you even after the course, if you want, I have some cases we can share with it together. Okay.
We have Dr. Mohammed after. First, we have our written. Then they actually now the oral they make it on December. They delay it 3 weeks more. So if you are, if you can,
over the weekend, Haytham, we'll be free over the weekend.
we can even because
Okay,
it's oral.
Talk to me, and we can get you some very good cases that you don't expect to see.
Okay.
Thank you so much, guys. I hope you